We can already get started. How did everybody's test go for week 1?
It's okay.
What is it?
I think it went pretty well. I think there was a lot of information to kind of like absorb and get a base for, but I felt like it was a pretty good.
Okay. Well, good. I just want to make sure like we're kind of following the same track. So, in case you guys had any questions or anything else. But okay, this test, like what I have to read to you is kind of lengthy. So if you guys have any questions or anything, just speak up or you can text in the chat. But okay, so Objective 1 is recognize expected physical, cognitive, and psychosocial developmental milestones in school age children and adolescents. So, school age children 6 to 12 years experience steady, slower physical growth compared to earlier childhood, improving fine and gross motor coordination and the cognitive shift into um, the concrete operational stage, meaning they can reason logically about concrete objects and events, understand conservation and cause and effect, and grasp the concept of time and sequencing well enough to benefit from advanced procedural explanation. Psychosocially, this is Erickson's industry versus inferiority stage. Inferiority, yeah. Self-esteem becomes closely tied to competence and achievement, and peer comparison becomes a major influence on self-concept. Adolescence, roughly 12 to 18 years, brings the physical changes of puberty. The cognitive shift into Piaget's, I don't even know how to say that guy's name, but that guy, formal operation stage. Um, and Erickson's identity versus role confusion stage, in which the central task is establishing a coherent sense of self, somewhat separate from parents, with peer group and romantic relationships taking on central importance. Um, some of your exam items commonly present an age and behavior and ask you to match it like to the expected cognitive or like psychosocial stage, and or like it's going to ask you to distinguish normal developmental variations from a concerning delay. So that's basically what it's asking you, is like using like Erickson's and stuff's logic with age groups. Objective 2 is understanding age appropriate activities that promote physical, cognitive, and social growth. So, for school age children, organize team sports, structured games with rules, reading, and hobbies that allow mastery of a skill, support the industry versus inferiority task by giving concrete opportunities to develop and demonstrate competence. Group activities and clubs like scouting and school clubs support the growing importance of peer belonging while still operating within adult structured boundaries. The child finds reassuring. Screen time and organized activity should be balanced. Current pediatric guidance emphasizes at least 60 minutes of moderate to vigorous physical activity daily for this age group to support cardiovascular health, motor skill development, and health weight trajectory. For adolescents, activity that support identity exploration are most beneficial. Part-time employment, volunteer work, sports, arts, and other structured extracurriculars that allow trying on different roles and interests in a relatively low stakes setting, along with unstructured peer socialization that supports normal identity and relationship development. The nurse's anticipatory guidance role includes counseling families on balancing autonomy with appropriate boundaries, encouraging continued physical activity as organized sports participation often declines in adolescence, and screening for healthy sleep habits since sleep needs remain high which would be 8 to 10 hours. That's recommended for adolescents, even as academic and social demands increase. Objective three, so it's identifying priority health promotion strategies for school age and adolescent populations. So, health promotion priorities for school age children include continued immunization per schedule, visual hearing, scoliosis screening, dental care, and injury safety education, nutrition and physical activity counseling to establish healthy patterns before adolescence, and beginning age appropriate education about body changes ahead of puberty so information arrives before anxiety does. Anticipatory guidance at this age also increasingly includes screen time slash media use counseling and early simple safety education about personal boundaries and appropriate touch. For adolescents, priority health promotion strategies shift towards risk behavior screening and confidential, developmentally respectful counseling. So, substance use, such as tobacco, vaping, alcohol, drugs, sexual health, and contraceptives, and STI prevention, mental health and depression slash suicide risk screening, and driving safety and healthy relationship education. The heads assessment, oh, sorry, the heads assessment or the home education employment activities, sorry, activities, drugs, sexuality, suicide, depression, safety is a widely used structured framework for adolescents' psychosocial screening and is frequently referred on exams as the tool for organizing a comprehensive adolescent visit. Confidentiality is itself a health promotion strategy since adolescents are more likely to disclose sensitive information and seek care when they trust their privacy will be respected. Objective four, so apply principles of safety education relevant to developmental stages, so like injury prevention or risk behavior reductions. School age safety education centers on the injuries this age group is newly exposed to as independence grows. Bicycle and pedestrian safety, sports safety, water safety slash swim competency, and stranger danger slash personal safety education framed in an empowering rather than frightening way. Because school age children reason concretely and values rules, safety education that gives clear, concrete rules tends to be more effective than abstract warnings at this age. Adolescent safety education must contend with the normal developmental drive towards risk taking and peer influence, combined with a still maturing prefrontal cortex that limits impulse control and long term consequence weighing even once abstract reasoning is present. This is why adolescents can understand a risk intellectually and still engage in it. Effective safety education leverages peer based approaches, honest, non judgmental discussions, graduated independence, and consistent messaging from multiple trusted adults. Um, what you're going to see on your test is like to select like different safety teaching approaches that best match the child's developmental reasoning ability. So make sure you understand those. Objective five, understand factors influencing self esteem, identity formation, and peer relationships. So, self esteem in school age children is built primarily through achievement and competence. Success in academics, sports, and social skills directly shapes self concepts during the industry versus inferiority stage, and children who experience repeated failure without adult support to reframe it are at risk for a lasting sense of inferiority. Family relationships consistent, positive feedback tied to effort rather than only outcome, and opportunities to succeed at developmentally appropriate tasks all support healthy self esteem at this age. Chronic illness, learning differences, or bullying are significant risk factors for eroded self esteem in this stage. In adolescence, identity formation becomes the central psychosocial task, and peer relationships take on outsized importance as adolescents begin to individuate from parents and test different roles, values, and group affiliations to determine who they are apart from their family or origin. Um, Body image, academic, extracurricular identity, cultural and gender identity, and romantic relationships all contribute to this process. Um, and peer rejection or bullying can significantly disrupt healthy identity formation and is strongly associated with depression and anxiety in this age. Um, the nurse is like you as the nurse assesses peer relationships and self-esteem as a routine part of adolescents' health promotion, not only when a problem is already apparent. Objective 6. This recognizes signs of psychosocial distress and appropriate nursing interventions. So, in school age children, psychosocial distress may present less verbally than in adolescents and more through behavior and somatic complaint, which would be school avoidance, declining grades, withdrawal from previous enjoyed activities, recurrent headaches or stomach aches without an organic cause, sleep disturbance or regression, because school age children may not have the vocabulary or insight to name what they're feeling. The nurse relies heavily on caregivers' report of behavior change combined with direct, simple, non judgmental questions to the child. In adolescence, distress may present as mood changes, irritability, social withdrawal, declining academic performance, changes in sleep or appetite, increased conflict with family, self harm behaviors, or explicit statements of hopelessness, any of which warrant direct screening for suicidal ideation. Since asking about suicide does not increase risk and is a necessary evidence based safety step whenever risk is suspected, appropriate nursing interventions include creating a private, confidential space for disclosure, using a validated screening tool when indicated, taking any disclosure of self harm or suicidal ideation seriously with immediate escalation to the appropriate mental health crisis resource, and never dismissing distress as normal teenage moodiness without further assessment. Objective 7. Discuss nutritional requirements and healthy eating habits for pediatric age groups. So, school age children need a balanced diet supporting steady growth with attention to adequate calcium and vitamin D for bone mineralization, iron for continued growth, and in menstruating adolescents, replacement of menstrual losses, and limiting excess added sugar and processed food to support healthy weight trajectory. This age is also a critical window for establishing lifelong eating patterns, making family meal structure, modeling of healthy choices by caregivers, and limiting screen time during meals meaningful, evidence supported interventions rather than minor lifestyle preferences. Adolescents have increased caloric and nutrient needs to support the puberty growth spurt, but often have the least structured eating patterns of any pediatric age group due to increasing independence, busy schedules, and peer slash social eating contexts, putting them at risk for both inadequate nutrient intake and excess intake of low nutrient processed foods. This age group is also the highest risk window for the emergence of disordered eating patterns. So, nutrition counseling is in adolescence should be framed around balanced, adequate intake and body function rather than weight or restriction. And the nurse should screen for rapid weight change, preoccupation with food slash weight, or competency behaviors as part of routine assessment. Objective 8. This is identify benefits of physical activity and ways to promote participation in developmentally appropriate activities. So, regular physical activity in school age children and adolescents support cardiovascular fitness, healthy weight maintenance, bone density, motor skill development, and academic performance, and is also protective for mental health, reducing symptoms of anxiety and depression, and support healthy sleep. Current guidance recommends at least 60 minutes of moderate to vigorous activity daily for children and adolescents with a mix of aerobic muscle strengthening and bone strengthening activity across the week. Promoting participation requires developmentally tailored strategies. School age children must respond well to organized sports and games with clear rules and opportunities to build mastery, while adolescents are more likely to sustain activity that offers autonomy, social connection, or identity expression, and may disengage from physical activity as academic and social demands increase unless it is actively supported. The nurse's role includes screening current activity level at every visit, providing anticipatory guidance about the expected decline in organized sports participation in adolescents, and help families identify activities that fit the child's interests and the family's resources rather than a one size fits all recommendation. Objective 9, applying nursing care principles for children with common acute conditions or chronic illnesses. For acute conditions in school age children and adolescents, nursing care follows standard priority settings while other while also addressing the age specific psychosocial needs identified earlier in this unit. School age children benefit from concrete explanation and involvement in simple care tasks, while adolescents benefit from being spoken to directly, offered privacy, and given a voice in decision about their own care whenever safely possible. For chronic illness management in this age group, the nursing priority increasingly includes fostering developmentally appropriate self management skill and independence. A school age child can begin participating in tasks like checking a peak flow or recognizing early symptoms, while an adolescent should be progressing towards largely independent disease management with parental support in the background, including preparing for the eventual transition to adult care. Non adherence in adolescents with chronic illness is common and often reflects the normal developmental push for autonomy and desire to fit in with peers. Rather than simple carelessness, and the nurse addresses it by involving the adolescents directly in problem solving rather than only reinforcing rules through the parent. Objective 10, recognize priority interventions for pediatric emergencies. So in week 1, airway, breathing, and circulation remain the universal first priority in any pediatric emergency, regardless of the child's age. And the nurse must remember that respiratory compromise progressing to arrest is the most common pathway to cardiac arrest in children, making early recognition and support of breathing the single highest yield intervention in most pediatric emergencies. For school age children and adolescents specifically, common emergencies include severe asthma, exacerbation, and status asthmaticus, anaphylaxis, traumatic injury, diabetic ketoacidosis in a child with known or new onset type 1 diabetes, and increasingly recognized as a priority. Mental health emergencies include acute suicidal crisis or severe agitation. For the anaphylaxis, the priority intervention is prompt intramuscular epinephrine, followed by positioning, oxygen, and antihistamine steroids as adjuncts, not substitutes. For DKA, priorities include fluid resuscitation, careful correction of hyperglycemia and electrolytes, and frequent neurological reassessment. For a mental health emergency, the priority is ensuring immediate physical safety while arranging urgent psychiatric evaluation. Um, for your test, make sure you know what emergency scenario would go with what, because they're going to ask about your first priority action. Objective 11, select appropriate communication strategies for school age children and adolescents. So, school age children respond best to direct, honest, concrete communication that explains the why behind procedures and treatments, since their concrete operational reasoning allows them to understand cause and effect logic when it is explained clearly. Involving them in simple decision and giving them a sense of mastery over their own care supports both communication effectiveness and their developmental need for competence. Using correct anatomical terms rather than um, euphemism or within reason, providing information slightly ahead of a procedure, and checking understanding through teach back or effective techniques at this age. Adolescents require communication that respects their emerging autonomy and need for privacy. Speaking directly to the adolescent, offering to speak with them alone for at least part of the visit, being honest about the limits and protections of confidentiality before they disclose sensitive information, avoiding a lecturing or um, authoritating tone, and using open ended, non judgmental questions, especially around sensitive topics. Objective 12 is plan and deliver effective patient and family educational tailored to developmental needs. So, effective pediatric education always accounts for the learner's developmental stage as well as the content itself. For school age children, education should be concrete, hands on where possible, broken into short segments matching typical attention span, and reinforce with praise for engagement and understanding. For adolescents, education is most effective when it respects their autonomy, uses evidence and rationale rather than simply instructing, and offers the adolescent an active role in the teaching interaction rather than a passive lectural format. Family education must run in parallel but distinctly. Parents of school aged children typically remain the primary managers of care and need full clinical detail, while parents of adolescents need coaching on how to support their teens, growing self management without taking over, since over involvement can undermine the adolescent's developing confidence and adherence. In both age groups, the nurse assesses health literacy and preferred learning style before teaching, uses teach back to confirm understanding rather than assuming comprehension because someone nodded, and provides written or digital take home material appropriate to the reading level of the family. Objective 13, applying principles from the Ericksons and Freud to pediatric assessment and care planning. Um, so, Erickson's um, psychosocial stages explain the child's core emotional task and the source of their self esteem, guiding the nurse toward interventions that support confidence building in school age children and autonomy/identity exploration in adolescents. Freud's psychosexual stages are less directly applied in modern pediatric nursing practice, but remain part of the historical theoretical foundation taught alongside Erickson's. The school age years correspond to Freud's latency stage, while adolescence correspond to the genital stage marked by the re-emergence of sexual interest and the developmental task of forming mature romantic and social relationships outside the family. Um, your exam items, they may ask you to match described children behavior to the correct theorist and the stage. So make sure you know those. Objective 14, identify age specific manifestations of developmental stages. So, recognizing whether a specific behavior represents expected development for an age or a deviation requiring further evaluation is a core pediatric nursing skill. In school age children, expected manifestations include increasing independence and self care, rule based reasoning, and a strong sense of fairness, best friend slash small group peer relationships, growing but still developing abstract reasoning, and still forming but increasingly stable sense of competence tied to achievement. Behaviors outside this pattern, persistent inability to follow multi step concrete instructions, complete social isolation, or marked sustained regression warrant further developmental or psychosocial assessment rather than being dismissed as just a phase. In adolescence, expected manifestation include increased conflict with parents as part of normal individuation, intense peer focus and shifting friend groups, exploration of identity across multiple domains, and inconsistent risk assessment even when abstract reasoning is present. The nurse distinguishes normal adolescent turbulence from concerning patterns by evaluating function. Is the adolescent still attending school, maintaining at least some relationships, and generally safe versus red flags such as a complete social withdrawal, dramatic personality change, dangerous risk taking, or expression of hopelessness, which move beyond expected developmental variation and warrant deeper assessment. Um, Objective 15, recognize pediatric differences in medication administration, pharmacokinetics, and safety precautions. So, while core pharmacokinetic principles were introduced in week one, so school age and adolescent patients bring additional practical medication safety considerations. As children move from liquid to tablet slash capsule formulations, the nurse must assess swallowing ability rather than assuming it based on age alone and must verify the child understands what a medication is for and how to take it as they take on more responsibility for self administration. Adolescents present distinct safety considerations. Increasing independence in taking their own medication requires the nurse to assess actual adherence and identify barriers such as not wanting peers to know about a medication, body image concerns affecting willingness to take medication with visible side effects, or intentional non adherence tied to risk taking or a mental health concern. The nurse also screens for interactions with substances on adolescents may not disclose voluntarily and provides education in a non judgmental way that maximizes honest disclosure. Objective 16, apply principles of atraumatic care during procedures and treatments. For school age children, atraumatic care includes explaining procedures concretely and honestly shortly before they occur, offering appropriate choices to preserve a sense of control using distraction and coping techniques the child can actively participate in, and praising cooperation and effort rather than only the absence of crying, since school age children are highly sensitive to perceived failure at this task mastery stage. For adolescents, atraumatic care shifts towards preserving privacy and dignity, offering an active role in decisions about their own procedure when appropriate, and respecting their right to ask questions and receive complete, honest answers rather than simplified explanations meant for a younger child. Pain management principles from week one apply fully here, and the nurse should not assume on adolescents' outward composure means they are pain free or not anxious. Um, you may see items on your test that you need to like select the coping strategy or the communicating approach of what child's developmental stage um, is described.
Hey, Michaela, would you mind to clarify Like, give me a couple of examples of the coping strategies.
Um, so I think it is meaning, um, with like school age, it's meaning like giving them choices like which arm, sitting up or lying down versus just like going in and making the decision for them. And then adolescence would be like knocking before entering, allowing them to remain clothed or as much as possible, or like keeping a blanket over them to be respectful of like their privacy.
Oh, okay. So I took that as like ways that they would present that they are coping. Or okay, so that's
Um,
more
I
our end.
think I think coping meaning like because they're in the hospital setting.
Hmm.
So it has to come from you. What would be a like a coping way for you to help them?
Got it.
So it
Thanks.
would be like giving them those choices or knowing how to be like respectful of their privacy.
Okay, good. Great. That makes sense.
Perfect. Um, okay, I think that pretty much explains all that. Okay, so objective 17, identify early warning signs of mental health disorders, eating disorders, and substance use in children and adolescents. So, early warning signs of mental health disorders in this age group include persistent changes in mood, sleep, or appetite, declining academic performance, social withdrawal, irritability, somatic complaints without clear organic cause, and critically, any statement or behavior suggesting self harm or suicidal ideation, which always warrants direct, immediate screening. Early warning signs of an eating disorder include preoccupation with weight slash body shape disproportionately to actual body size, rigid or ritualized eating behaviors, or skipping meals, or excessive or compulsive exercise, withdrawal from food related social situations, or rapid or unexplained weight change, and in some presentations, signs of purging behavior. Um, Sometimes, especially with like kids with like the purging, you may see questions about like dental enamel because they will have like erosion on their teeth from like vomiting so much, and um they may have like calluses on the hands from like making themselves vomit, or electrolyte imbalances, of course. But early warning signs of substance use include sudden changes in peer group, declining school preferences, secrecy changes in sleep slash appetite, unexplained financial needs, physical signs specific to the substance, and mood changes not otherwise explained. The nurse's role in all three categories is early, non judgmental, direct screening as a routine part of adolescent health visits, since early identification significantly improves outcomes and stigma free screening increases the likelihood of honest disclosure. Objective 18 discusses prevention and early intervention strategies for high risk behaviors. So, prevention of high risk behaviors is most effective when it combines individual level factors with environmental level factors. No single intervention is sufficient on its own, and prevention is most effective when started before high risk behaviors emerge rather than only after a problem is identified. Early intervention strategies, once a concern is identified, include brief, non judgmental motivational conversations, connecting the adolescent and family to appropriate specialty resources, maintaining confidentiality within legal limits to preserve the adolescent's trust and willingness to continue engaging in care, and involving the family in a way that supports rather than shames the adolescent. The nurse's role is to screen consistently, respond to positive screens with calm, direct follow up rather than alarm, and facilitate connection to appropriate resources rather than attempting to manage a significant mental health or substance use concern alone. Objective 19, discuss how family dynamics, culture, and community resources influence pediatric health outcomes. So, family structure, communication patterns, and level of parental monitoring slash involvement significantly influence school age and adolescent health outcomes. So, consistent, warm, and appropriate monitoring parenting is associated with better outcomes across nearly every domain covered in this unit. So, like nutrition, physical activity, mental health, risk behavior, and chronic illness management, while family conflict, inconsistent structure, or parental substance use slash mental illness are recognized risk factors requiring additional nursing attention and family level intervention, not just child focused teaching. Culture continues to shape health beliefs, communication style, expectations around adolescence, autonomy, which vary considerably across cultural backgrounds, and comfort discussing sensitive topics like sexuality or mental health, and the nurse must assess and respect these differences rather than applying a single cultural standard for what healthy family involvement looks like. Community resources, so school counselors and school based health centers, community mental health services, after school programs, faith communities, and youth serving organizations often serve as a practical bridge between a recognized need and actual access to help, particularly for families facing financial or transportation barriers, making nurse familiar making nurse familiar with local referral resources a meaningful part of comprehensive care for this age group. Last but not least, Objective 20. So, this recognizes the role of the nurse in advocating for children within the healthcare and school systems. So, within the healthcare system, the nurse advocates for ensuring the child and family's voice is included in care planning, escalating concerns when a child's needs are not being adequately addressed, ensuring appropriate informed assent and obtained for school age children and especially adolescents whenever feasible, and protecting confidentiality and dignity, particularly for adolescents navigating sensitive health concerns. The nurse also advocates by identifying and reporting safety concerns and by connecting families to needed resources rather than assuming the family will independently find them. Within the school system, the nurse advocates for supporting appropriate accommodations for children with chronic illness or disability, like a 504 plan, individualized educational programs, communicating relevant health information to school staff with proper consent, and serving as a liaison between family, healthcare provider, and school to ensure a consistent, coordinated plan across settings. This advocacy role is especially important for children whose chronic illness, mental health condition, or developmental difference could otherwise be misunderstood or inadequately supported in the school environment, and it represents a natural um, accumulation of this unit's focus in integrating developmental, psychosocial, and health system knowledge into whole child care. So basically, your whole test is based off of school age versus adolescence. So make sure you guys know what the difference is and what the age gap is between all of them, and know your stages because they're going to ask questions based off of the stages. Otherwise, that's all I have. That's it.
So, Michaela, when you mentioned stages, mentioning those developmental stages mentioned by like Freud or Erickson,
Mhm.
yeah, is that what you're saying?
Yes, yeah, like understanding those, like all of those, make sure you know what stages for what, like, especially in like the adolescent and school age.
Okay, great.
Because
Um,
they'll ask like examples, like I don't I don't have your test sitting in front of me, but I know it was mentioning stuff about, like, a lot of stuff about Ericsson's
Okay.
when I had seen it, but also it's asking other questions as well, like, things that you would like, examples you would base it off of, I guess,
Okay, that's helpful. Thank
without
you.
giving you, like, the answers. Yeah, just make sure you know your stages.
That's great. Thank you.
You're welcome. Anybody else have any other questions? This is the worst part of peds. Otherwise, I hope you guys have a good week and good luck on your test. I'll see you guys next week.
Thank you.
You're welcome.
Thank you.
You're welcome.